Ladies and gentlemen, distinguished guests, I want to acknowledge the traditional custodians of the land on which we meet and pay my respects to their elders past and present. I also want to acknowledge the Rickards family and other distinguished guests. I'm honoured and flattered to be asked to address you today in this year's Winston Rickards Oration. Dr. Rickards devoted his professional life to the care of children, young people and their families through the integrated application of a multidisciplinary approach. He enriched the field of mental health immensely, and he enriched the lives of many children and young people he helped immeasurably. We'd also like to pay our respects to people with lived experience of mental health issues, their families and other supporters. Particularly we commemorate those who have been before us and travelled this journey. Through their courage and efforts, we and others are able to stand here more respected and with a strong voice. Ladies and gentlemen, after dinner or evening, orations often fall into three parts. In the first part, the speaker says how honoured he or she is to have been invited to speak, which I certainly am. In the second part, with apparent humility and modesty, the speaker points out how undeserving of this honour they are. And the third part is a lengthy demonstration of why they so undeserving of the honour. I want to get to the third part of my speech straight away. I want to tell you how I got involved in mental health, and then I'm going to talk about some mental health issues, and then some comments on youth and adolescent mental health. 17 years ago, my daughter Isabella, now aged 41, was diagnosed with schizophrenia after a prolonged period of disturbing, distressing, bizarre behaviour. Her first 18 months seemed normal, but from then to adolescence, worrying. She had many difficulties, much unhappiness in her childhood years. At 18 months, she used to tear her hair, becoming bald on certain parts of her head. She did many strange things. In childhood and throughout her life, she was never able to relate to a peer group, to play with them, to be included in their activities, to communicate. She depended on her parents and other adults for her mental stimulus. Her adolescence was tormented and troubled at home, school, everywhere else, and ever increasingly so. An embarrassing obsession with another student led to the first of several changes of school. She received a great deal of psychotherapy from psychiatrists and psychologists, who she also saw from age 12 till 26. During all this time, she never received any diagnosis of mental illness, and the deep fears of her family in that regard were never confirmed, supported, or indeed to some degree they were discouraged. At 26, she had a full psychotic episode. She heard gunshots and other noises in her head and kept seeing monsters and other frightening images. After receiving a diagnosis and taking medication on a substantial scale, her severe psychotic symptoms were largely removed and she returned home from hospital, but she continued to be very obsessive and had difficulty communicating and concentrating. 8 years ago, she lapsed into an extremely psychotic condition, culminating in a 3-month stay in a high dependency ward of a public hospital. Eventually, she had ECT treatment. Although these severe symptoms were eventually removed and a seemingly appropriate form of medication was applied, she was adversely affected by the episode in terms of obsessiveness, lack of concentration, and spent time in a community care unit attached to the hospital with a 24-hour nursing service. Now, Isabella does now receive treatment from a psychiatrist, takes medication that generally deals with the psychotic symptoms. She's a lovable, charming, sensitive, articulate, intelligent woman, but even with medicine, her illness can cause serious difficulty in comprehending reality. She has frequent obsessional behaviour, sometimes socially inappropriate behaviour, lack of motivation, quite poor living skills. Well, the second bit of the story is about her accommodation and long-term care. In 2003, a group of carers, including my wife here tonight, got together concerned about finding secure, stable accommodation for their children, all of whom suffered from high-impact mental illness, all very vulnerable, that required them to have support, care, accommodation on a long-term basis, even beyond the time that we could care for them. The Catholic parish of South Yarra had a disused convent. Instead of selling that for a lot of money, it provided it at low rent as part of its social commitment. The carers then drew up a model of accommodation, care and support. 8 years later, that idea finally came to fruition. The outcome has been one that meets a really important unmet need in our community. We have 14 people who'd otherwise be in hospital or high intensity care, or maybe homeless or in temporary accommodation before relapse and re-entry into hospital. They're at a haven. In short, we have an innovative model that provides accommodation, care and support in a setting that provides independence for residents, but also an opportunity for them to live as a community. An especially innovative feature is that families and carers, as well as residents, play a very substantial role in the project, trying to overcome some of the problems that often arise in such settings when mental health workers don't engage with families and carers or don't do so properly. A recent Monash evaluation found a considerable improvement in the lives of the residents, including Isabella, and that confirms our own observations and of everyone who knows the group. But Isabella was lucky. There's a huge waiting list. That's a one-off solution, not a system-wide solution. Housing authorities and governments need to do more than provide indifferent hostels where people languish without hope. Having a home where one feels safe, stable and secure is in the National Mental Health Commission's sights as a core right and a critical foundation for recovery. So my next involvement is as chair of the National Mental Health Commission, and I'll talk now briefly about its role. One unusual feature of the Commission is that they have an economist to chair it. Usually this is the province of psychiatrists, psychologists, social policy experts, so I'm going to give a little bit of attention tonight to some economic questions in the field. Now, I do think economics has something to offer in understanding mental health services. It's very important for the mental health community, as we've already heard from Susan, to engage in dialogue, but especially with treasuries and finance departments, as well as business. And economics is relevant to some of that ongoing dialogue. But I don't want to say it's the only aspect of policy. I believe that even if there was no economic benefit in looking after people with mental illness, it would still be a major moral and social obligation to do so. So the Commission was launched, as Susan mentioned, in 2012. We're independent. Our role is to report to the public, to hold governments to account for their commitment to improve outcomes for countless numbers of Australians and their families, and reveal the full truth about the provision and delivery of mental health services in Australia. We exist because the mental health community has for some time felt that neither of these things was happening. Our composition is quite broad. 2 carers, including myself, 1 person with lived experience of mental health, a housing and social welfare provider, an Indigenous psychologist, a psychiatry specialist, a distinguished general practitioner professor, a businesswoman, a former state health minister. We're located in the Prime Minister's portfolio. We hope that's a sign of the priority the government is giving mental health. But we also believe this reflects an understanding, both within government and our commission, that mental health issues are whole of government issues. Nearly every department I can think of, federal, state, local government even, has some interest in mental health. Just at Commonwealth level, we would have health, ageing, families, Indigenous matters, community, housing, immigration, defence, education, health, employment, veterans affairs, treasury, finance, attorney generals, foreign affairs. The whole lot have some interest in mental health departments. A little bit about our views and philosophy. We believe that mental health needs to be a much higher and continuing priority for governments and communities. Too often, there's a momentary passing surge of interest in mental health, a few accompanying measures, and then it drops off the agenda for another few years. We want it to be a continuing priority. And we also believe that it's right that people with mental health problems want the same thing as everyone else. Even the most disadvantaged should be able to lead a contributing life. That can mean many things, the idea of a contributing life. A fulfilling life, enriched with close connections to family and friends, good health and well-being to allow those connections to be enjoyed, having something to do each day that provides meaning and purpose, whether it be a job, supporting others, volunteering, and a home to live in, free from financial stress and uncertainty. We released our first report called A Contributing Life last year, and we highlighted the need for a more complete picture of mental health in Australia. There are heaps of data about how much we spend and the activities, very little about the outcomes or the impact and experiences for persons with lived experience of mental health or their families and carers. So we believe there should be a shift in the focus of collecting data to tell us more about what's really happening to people in Australia with poor mental health. We made 9 major recommendations. Many have some relevance to youth and childhood mental health issues. And by the way, we're going to talk more about that in our second report. Our overarching view and recommendation was that government makes a higher continuing priority of mental health. But we specifically recommended 1, nothing about us without us. That is, there must be a regular independent survey of people's experience of and access to all mental health services to drive real improvement. Increase access to timely and appropriate mental health services and support from 6 to 8% to 12% of the Australian population. Reduce the use of involuntary practices and work to even eliminate seclusion and restraint. All governments to set targets, work together to reduce early death and improve the physical health of people with mental illness. Include the mental health of Aboriginal and Torres Strait Islander people in closing the gap targets to reduce early deaths and improve well-being. There must be the same national commitment to safety and quality of care for for mental health services as there are for general health services. Invest in healthy families and communities to increase resilience and reduce the longer-term need for crisis services. Increase participation by people with mental health difficulties in employment. No one to be discharged from any mental health or other services into homelessness, and access to stable and safe places to live must increase. So our emphasis is on a whole-of-life approach, not just a clinical approach to mental health. People with poor mental health don't live their life in silos, with their mental health over there, housing there, physical health somewhere else. Their entire lives affect and are affected by the mental and emotional well-being that they have, and we believe this means there needs to be an integrated approach to dealing with the complex challenges of mental health. And the involvement in the Commission of persons with lived experience and of carers helps keep us focused on that aim. Now, what I wanted to do was to make a couple of comments on the National Disability Insurance Scheme. It's long overdue, very welcome. I'm pleased at the fact that there's bipartisan support. I want to emphasise that mental health problems and associated physical health problems can lead to lifetime impacts that are just as disabling as sensory, intellectual or physical disabilities. Our report card clearly stated that there must be no competition. Disability is disability, whatever the cause. Any systematic response to disability must include consideration of the impact of mental illness upon some people's ability to participate in education, the workforce and other activities that support a contributing life. So 3 specific comments. It's critical that the NDIS applies to persons, not only those with physical disability, but also those with significant and enduring psychosocial disability arising from mental ill health. Second, it's essential that the rules which are behind the implementation of this and determine how the scheme will work don't disadvantage people with psychosocial disability, including those with just episodic occurrences of mental illness. Third, we must note that the NDIS, by the way, the government has said that it will apply to an important category of persons with mental illness. At the severe end with psychosocial disability, probably with continuing rather than with just on and off episodes of mental illness. But it's very important to mention NDIS at best only covers a small part of the population with mental illness and only a small part of the persons with serious mental illness or so-called low incidence. So there are many other persons with mental illness outside the proposed NDIS who need care, treatment, support, accommodation, employment and other services. We must not forget them. And I want to talk about a few economic issues that come up in mental health. And just to look at the subject, you immediately see lots and lots of questions that come up. What's the cost to society in economic terms of mental illness? How much should be spent on it compared to other illnesses, compared to other social expenditures? Could we improve the spending that we do on mental health by allocating it better costs and benefits of various programs? What is the role of the market? What's the role of government and of individuals? What's their relationship? What's the role of incentives? I can't give you some examples. What are the best ways of funding mental health services? Well, let me dwell on economic questions for a few moments. One of the obvious things is assessing the costs to the economy of mental illness. There have been some good cost studies. We could do with some more. Just to give you one example, Ernst & Young, in a study for the Inspire Foundation, studied the impact of young men's mental health on the economy. Mental illness in young men aged 12 to 25 costs the economy $3.27 billion per annum, or $387,000 per hour across a year in lost productivity. We lose over 9 million working days per year to young men with mental illness. The OECD report, Sick on the Job, points out there's further productivity losses from people at work who have mental health problems, leading to underperformance. So this and many other studies about the cost of mental illness, and also the potential benefits from tackling it successfully, are something where there can be a contribution from economics that speaks to some of the important decision makers in government. Then an interesting recent study by Medibank Private showed that, a little bit to our surprise, Australia spends $28 billion a year on mental health, or mental illness, mainly at state level. It's a lot more than we thought. We used to say 13 billion. They take into account other costs: income support, housing services, domiciliary care, employment and training. And that means that we spend 2.2% of GDP, excluding indirect costs like productivity. For those of you who haven't studied economics, GDP is a technical term meaning grossly distorted parameters. What stands out rather obviously when you go through a look at all the spending going on in mental health is that we have done very little assessment of how well the resources are spent. We do know that there's a fairly low proportion of the population that gets access to mental health services compared with the number of community who need it, compared to the access of the population to other medical and health services compared to the number who need it. We also are worried about the high incidence of mental health problems despite the spending on it. So would it pay to spend more? Is it that we don't spend the money well? Is it that we spend the money well in the circumstances, but the solutions aren't available or aren't perfect? Is the balance right between prevention and care? Is the balance right between clinical or hospital spending and spending in the non-clinical, non-hospital areas? I'd just say one thing. Having had this rather higher than expected figure mentioned in public, it's important that it's not used as a reason to disinvest in mental health. Indeed, a lot of that slightly high, unexpected spending on mental health is because we're not spending the right money in the right ways. Things are going wrong, generating all these other costs that we hardly ever think about. Let me just dwell on a few other economic points. As I said, it's very interesting to keep an eye out for incentives. Sometimes incentives can be perverse, creating a people or organisations to do exactly the opposite of the intent of the policy or the program. So let's look at the current hospital reforms, the big national hospital reforms. Under the reforms, as most of you would know, the Commonwealth will soon pay 50% of the increase in state and territory hospital spending. That will give states a major incentive to move mental health services from the community, where they pay 100%, into hospitals, where they pay 50%. That reverses, or threatens to reverse, the work of many years in which we've been trying to keep people with mental illness out of hospitals wherever possible and supported to stay well in the community. Years of effort in moving to contemporary and innovative practice threaten to be undone. We believe it's better for people to be treated in their community, very often by excellent non-government organisations with links to rehabilitation, housing, employment, rather than, except where necessary, in hospital beds in a clinical or hospital setting, except in acute cases. They can also be with or near their families and friends. Costs are usually lower. This is a people-centred approach that considers their whole life, not just health aspects. And this focus somewhat artificially slices up an ideal system of integrated cross-sector, community-based support, which should focus on what the person wants and needs, not where the money comes from. Now, another aspect of the reforms is so-called activity-based funding, or a pricing system, which in general I think is not such a bad idea for allocating resources to hospitals. What they do is they identify an activity, say it's a standard knee operation, they figure out what the average cost is, they ask how many of that does the hospital do, and then they allocate money, the number of operations of knees by the average cost. There are arguments for it, it's probably a good system. In mental health, and it looks as if it's coming in, it's very problematic because it's unpredictable how long each treatment can take. It might take a day, it might take 6 months. Difficult to run an average costing system in this setting with such wide variation. And also, that system does have potential distortions with gaming, pressure to get rid of patients more quickly. Those things could be quite a big problem in mental health. It's really important that if the government brings in pricing for mental health, that it doesn't seriously undermine effective and efficient care. Now, one other accessibility issue, of course, is that under our provider number system, fee-for-service in Medicare, any qualified psychiatrist or psychologist can get a number and set up practice wherever they like. They tend to live in better off areas. There's an abundance of services relatively in those areas. A relative scarcity in other parts of Australia where they don't live. And that is the result of incentives created under the Medicare scheme. Well, you may still be a little sceptical of economic views, but let me talk now about something that is more relevant to youth and adolescent people, and that is the work of Professor Allan. He actually won the Nobel Prize in economics for this work, very important recent contribution of economics. He established through a lifetime of work, something that is now becoming the accepted wisdom, that investing in high quality programs targeting very young children and their families to assist in the development of emotional and social skills have proven substantial economic returns. His special contribution was to show, through a series of studies, that the economic return of investing in high-quality early childhood programs consistently far exceeded that of other social investments. The benefits consistently exceeded 3 to 1. For every $1 spent, a $3 return, well above the return of most other government investments. And he argues that they have a much higher return than later interventions. But significantly, programs aimed at older age groups show more return for children who have already had the benefit of intervention in preschool years. So the efficiency, the efficacy of help and support for school-age children and adolescents is increased by investment in high-quality early childhood development. And programs targeting the early years with, for example, home visits to affect the lives of the parents and create a permanent change in the home environment that supports the child, even after that part of the program delivered through childcare or community centre ends, have the most promise, as do programs that don't focus exclusively on academic or cognitive abilities, but more generally on building emotional and social skills. There's a famous study of the Perry program in the US that spells out some of the details on that in a very conclusive way. And that links, of course, with greater improvements in neuroscience understanding of the brain and how it works. That helps us understand why that early investment pays such dividends. The science of early childhood development is now showing the impact of experience and environment on young people, not just at the time but throughout their lives. As young people's brains develop their neural networks, which lay the foundation for such essential social and socio-emotional skills as language, self-regulation, social skills and compassion, the shape and strength of this development depends heavily on the environmental input. And over time, the brain is less adaptable, less flexible, and the effects of early childhood, good or bad, are harder to undo as time passes. And prevention thus has a really big upfront impact prior to the onset of a problem. And early experiences can start a development trajectory which may be positive or negative, to susceptibility to conditions such as mental health problems, but also including family violence and antisocial behaviour, participation in crime, poor literacy, early school leaving, subsequent poor skill levels, welfare dependency, substance abuse, obesity and its associations. High quality early childhood and family support programs can do much to prevent this happening. Those interventions include early childhood education and intervention programs, parenting and family support programs, and they not only improve cognitive and socio-emotional function, but they tend to be quite cost-effective, especially for children from disadvantaged backgrounds. So this is a multifaceted issue. Appropriate support in early childhood encompasses educational goals, but also social and emotional ones. Now, in terms of what works, it would point to interventions to promote attachment and development, effective universal programs for all families, such as maternal, infant and child health services, high quality education and care, targeted programs for those with greater vulnerability, such as intensive home visiting, parenting programs, supported playgroups. Let me say a few words on adolescence. Just as we now have an increasingly sophisticated understanding of the significance of the first years of life in the development of a healthy mind, we also now know more and more about the implications of continuing brain development through childhood and into the key transitional years of adolescence and early adulthood. Those years, 12 to 24, see the emergence of mental health symptoms for 75% of people who will experience poor mental health throughout their life. Now, although there is a perception that young people are reluctant to seek help for mental health problems, adolescents and young people themselves say that they have sought information and help, and they want access to more. The barriers they identify include cost and availability, with the fear of being stigmatised and shamed out a substantial obstacle as well. Now, many mental health professionals, government representatives, MHYFVic, people like me, live on the other side of the generation digital divide. We can sort of see, but not quite grasp, the increasingly fluid distinction between online and offline life for the generation of Australians who don't remember life before smartphones. At the same time, our traditional models of consumer activism, and Susan touched on this at the beginning, like peak lobby groups and advocacy organisations, seem a bit outdated and lumberingly slow to the Twitter generation, proficient in quick and effective social media campaigns and network engagement. We need to engage with young Australians on their own terms, including through the use of peer researchers, which itself raises some different important perspectives. It's our responsibility to make our feedback and data collection processes accessible and engaging, to listen to what young Australians have to tell us about what they need and what they want from mental health care and support. Now, the Commission recently commissioned a report about how to engage with young people, and today we're happy to release that report, and many thanks to BADA CEO Sebastian Robertson, Young and Well CRC CEO Dr. Jane Burns, Dr. Michelle Blanchard, Head of Projects and Partnerships at the Young and Well CRC, who are here this evening. Thank you for your work in developing this informative report. It's important to realise that children, adolescents, young people engage with help, support and care differently to older adults. A GP might be the first port of call for an older person seeking help. Young people see that as a less desirable option. A mental health care system designed around the preferences of the older members of the community, designed in the previous century, is not necessarily meeting all the needs of young people, is online. Many young people prefer to access help, support and care through digital mediums. And for those living outside major metropolitan centres, often it's the only access, and it provides privacy for those worried about stigma, and through forums and networks, a community of shared experience. The overwhelming preference for young people, we survey, is to get information on mental health from another young person with lived experience of mental health. Of young adults, 93% go online, 33% of them look for mental health information online. And given that half of our mental health problems are evident before 15, e-health technologies are familiar and easily accessible to young people. Christensen and Hickey conclude there is increasing evidence that internet-delivered treatments are effective, efficient and cost-effective for anxiety, depression, post-traumatic stress disorder and a range of other conditions. Australia has got some groundbreaking programs that work in this area. The Inspire Foundation's Reach Out is now being used around the world. Headspace has both online and offline help and support, and has had particular and remarkable success in engaging young men who are less likely than young women to seek health. And indeed, Headspace centres are an example of providing integrated face-to-face services in an accessible setting which reflects the preferences of adolescents and young people. Well, there are many more things that can be said on adolescence and early childhood. I wanted to emphasise, however, that the Commission's recommendations are informed by a holistic, family-centred approach across the whole life course, similar to that informing the NDIS. People with mental health difficulties don't live their lives in distinct segments with mental health care in one box, education in another, housing in third, employment in yet another. And in addition, there are many complex issues, as most of you in this audience know, for people who have both a mental health problem and an intellectual disability. And for people and children and young people, situations where a child comes from a home with a parent or caregiver suffering mental illness. Nor do they live their lives in compartmentalised development stages with a calendar birthday bringing a comprehensive change in support needs or abilities. A whole-of-life approach means not only on the horizontal plane, but vertically. I've talked a bit about age cohorts today, but they're not really neatly segregated from each other, and their needs are complementary, not competitive. But because they are, of course, made up of the very same people as they transit through life. A whole-of-government approach demands a whole-of-government, a whole-of-life approach, a whole-of-person approach demands a whole-of-government approach, and more than government, our approach must include non-government sector, business and community as a whole. So I don't want to suggest tonight that child and youth services and programs are the only places we should be putting our attention and resources, but rather it's clear to me, and perhaps with a little bit of the hand of an economist on, that the key development stages are currently a missed investment opportunity for our community. Developing a comprehensive population-based approach to promoting good health and addressing poor mental health, which integrates with clinical services where necessary, isn't an easy task, but it is an essential one. Thank you.